everybody! This video is going to give you a quick introduction to sedation and paralysis in the ICU. I always like to start with definitions. In simple terms, sedation is using medications to calm patients and reduce agitation, while paralysis is the use of medications to inhibit skeletal muscle contraction. It's important to never give paralysis if a patient isn't adequately sedated. Similarly, it's important to remember that sedation and paralysis serve different functions. If a patient is awake and crying, muscle relaxants will indeed stop the behavior, but not in a very humane manner. Instead, address the issue with sedation before giving paralysis. So, why do we sedate our patients? A main reason we use sedation is to improve pain control and patient comfort. Often, this means minimizing postoperative pain or the discomfort associated with the procedure, but it can also be simply trying to improve patient comfort while they're intubated. When kids are very anxious, our first choice is always non-pharmacologic measures. When that is not sufficient, we sometimes use low-dose sedation for anxiolysis, as severe anxiety may actually interfere with healing. Another goal of sedation is amnesia. Ensuring that the patient does not remember painful or frightening procedures improves patient comfort and reduces distress. Sedation decreases metabolic demand, so we utilize sedation for kids in shock to ensure that their cardiac output is utilized as effectively as possible. It can similarly be used to maintain low intracranial pressure in patients who have traumatic brain injuries. Sedation can be used to help patients maintain synchrony with the ventilator to allow their lungs to recover from conditions such as ARDS or pneumonia, and finally, can sometimes just be used to ensure that essential lines, tubes, and other devices can remain in place. These are some of the most common IV agents we use for sedation in the PICU. We'll talk about each one of them now. Morphine is probably the most commonly used sedative in the PICU, and one with which I'm sure you're all familiar. It's an opioid analgesic, so functions primarily to reduce pain. Morphine can cause respiratory depression or apnea, so should be used with caution in patients without a secure airway. It can also cause hypotension. Less severe but potentially quite bothersome side effects can include itching, nausea and vomiting, urinary retention, and constipation. IV morphine begins to act within 5 to 10 minutes of administration, reaching peak effect in around 20 minutes. The effects typically last 3 to 5 hours. We start our morphine infusions at 10 to 20 micrograms per kilogram per hour. Bolus doses are typically between 0.05 and 0.1 mg per kg. Fentanyl is another very common sedating agent in our unit. It's a synthetic opioid that, like morphine, functions primarily to reduce pain. Compared to morphine, fentanyl takes effect and wears off more quickly. The side effects of fentanyl are the same as those seen with morphine, with one notable exception. When fentanyl is administered via IV push, it can cause chest wall rigidity, making it essentially impossible to move the chest with bagging. The treatment for rigid chest is paralytic. Fentanyl begins to take effect within 2 to 3 minutes of administration and lasts for 30 to 60 minutes. We typically start our fentanyl infusions at 1 to 2 mics per kilo per hour. Bolus doses are typically 1 mic per kilo, although many of us use 2 mics per kilo for intubation. Hydromorphone, or Dilaudid, is the third opioid analgesic you may encounter in the PICU. It has the same side effects as morphine, including respiratory depression and hypotension, but some people think it is less likely to cause significant itching or nausea, and indeed we often switch to Dilaudid when a patient has significant side effects from morphine. Dilaudid takes effect within around 5 minutes, with peak effects in 10 to 20 minutes. It lasts for 3 to 4 hours. We start our Dilaudid infusions around 1.5 mics per kilo per hour. Bolus doses are typically 0.015 mg per kg. Dexmedetomidine, or Precedex, is a selective alpha-2 agonist with sedative and some analgesic effects. Although it can be given as a bolus, we only use it as a continuous infusion in our unit. The most common side effect is bradycardia, which occurs to some degree in most patients. Because of this, it should be avoided in patients with heart block or baseline low heart rates. It can also cause both hyper and hypotension, although these are much less common. Hypotension in particular occurs almost exclusively after bolus dosing. Respiratory depression is almost never an issue with Dex. Dexmedetomidine begins to take effect within 10 to 20 minutes, reaching its peak after 60 minutes. It has a duration of 1 to 4 hours, but does not have to be completely out of the system prior to extubation, as it does not generally suppress respiratory drive. We typically start our infusions at 0.25 mics per kilo per hour and increase in 0.25 mic increments up to around 1 or 1.25 mics per kilo per hour. Propofol is a general anesthetic with no analgesic effects. We commonly use it as a washout to clear other, longer-acting agents prior to extubation, or occasionally to facilitate procedures. It should be avoided in patients with egg or soy allergies, and generally is not a good choice in hemodynamically unstable patients. Adverse effects of propofol include respiratory depression, hypotension, and rapid transition to deeper levels of sedation. Patients also complain of burning at the IV site when it's given peripherally, and it can turn urine green. In kids, propofol infusion syndrome is a very serious, often fatal condition that can arise with prolonged use, so we generally avoid using propofol for more than a couple of days. Propofol takes effect quickly within 30 seconds of administration, and a single dose will wear off within 5 to 15 minutes. It's very lipophilic, however, and longer administrations tend to accumulate and may take longer to wear off. In our unit, we typically start at 25 to 50 mics per kilo per minute and rapidly increase by 25 mic intervals to the desired effect. We generally use 1 mg per kg boluses, but may use smaller doses in larger patients. Ketamine is another general anesthetic, but unlike propofol, has analgesic as well as sedative effects, making it a good choice for painful procedures. It has bronchodilator effects as well, so is also a good choice for asthmatics, and whom opioids should generally be avoided if possible. It is less likely to cause respiratory depression or hypotension than other agents, and in fact may raise blood pressure and heart rate, so can be used in patients without a stable airway and those who have the potential to become hemodynamically unstable. It should be avoided in patients with TBI or eye injuries, as it may raise intracranial pressure and intraocular pressure. It can cause vomiting, so some people premedicate with Zofran. It can also cause emergence reactions and hallucinations, particularly in older kids. This can usually be avoided by giving a small dose of Versed before waking the patient. Laryngospasm is a rare side effect seen more commonly with IM administration. When given IV, ketamine takes effect within 30 seconds. Onset is slightly slower after IM administration. Its main effects last for 5 to 10 minutes, although patients typically don't return to baseline for 1 to 2 hours. We tend to start infusions at around 0.1 mg per kg per hour. It's more common to use ketamine as a bolus in our unit, which we usually dose at 1 to 2 milligrams per kilogram. Finally, Versed, or midazolam. As you likely know, Versed is a benzodiazepine, and as such has sedative, anxiolytic, and amnestic effects, but does not provide any analgesia. Risks include respiratory depression and apnea, particularly when administered with an opioid. It can also cause hypotension, vomiting, and paradoxical reactions, including hyperactivity and aggression. It has also been shown to be a significant contributor to ICU delirium. Midazolam takes effect within 1 to 5 minutes of IV administration, with peak effect in 3 to 5 minutes. It lasts for 15 to 60 minutes. Like morphine, our infusions generally start at 10 to 20 mics per kilo per hour, and bolus doses are typically 0.05 to 0.1 mg per kg. Now that you're familiar with the common sedation agents used in our unit, let's talk about paralytics you may encounter. Vecuronium is the most common paralytic used in the PICU. Like the other agents we will discuss, it is a non-depolarizing neuromuscular blocker. Like all paralytics, it lacks sedative, amnestic, or analgesic effects, so should never be used without adequate sedation. Adverse effects are rare, but can include the findings listed here. Onset occurs within 2 to 3 minutes of administration, with peak effect in 3 to 5 minutes. Note that the effect is not immediate, so for procedures such as intubation, it's important to pause after administration to give time for the drug to take effect. The effects dissipate within 25 to 65 minutes. Continuous infusions are generally run at 0.1 milligrams per kilogram per hour. The bolus dose is 0.1 mg per kg. Another paralytic option is rocuronium. Roc has a slightly faster onset and elimination than VEC, and is therefore frequently used for RSI. It can be used as a continuous infusion as well, but we typically use VEC for that purpose. Adverse effects can include increased peripheral vascular resistance, tachycardia, hypertension, transient hypotension, and hypersensitivity. Onset occurs within 60 seconds, reaching peak effect in under 5 minutes. Effects last for 25 to 40 minutes. As mentioned, we typically don't use continuous infusions of Roc. The bolus dose is 1 mg per kg. Finally, cisatracurium. Cis is less common than VEC or Roc in our unit, but is the preferred choice in patients with hepatic or renal disease, as it's metabolized via Hoffman elimination and doesn't require good end organ function. Side effects are rare, but can include those listed here. Onset occurs within 2 to 3 minutes of administration, with peak effect in 3 to 5 minutes. Duration of effect is 35 to 45 minutes. If used as a continuous infusion, we typically start at around 0.2 milligrams per kilogram per hour. The bolus dose is 0.15 mg per kg. That concludes our introduction to sedation and paralysis. Hopefully you'll get plenty of opportunities to learn more about these drugs during your time in the ICU.